I'm glad today that we'll be talking and we'll be discussing treatment failure and how to identify it. And so we are privileged to have a didactic presenter this afternoon, Dr. LOTTIE HACHAAMBWA. He will be able to introduce himself much later and give us a bit more details about him. So we want to thank also our network, the different provinces that have joined this afternoon. We appreciate your continued participation on this platform. And we hope this is providing you an opportunity to share best practices, learn some of the new techniques and skills on how to provide HIV services to our clients. So we also want to thank the different provinces that participated in doing cases. So today we'll have a case from Kabwe, we'll have a case from Mchinga, we also have cases from Eastern Province, and also Southern Province, as well as Western Province. So we want to appreciate the input that our colleagues have put in to just put these cases together. And so I also wanted to say that we will, this time around, we'll do an auto breakout session, meaning you will be put in according to rooms, not particularly in your provinces, except the cases. I think the cases we've discussed where you will be placed. So just make sure that you label your, as you've connected from Kabwe, just indicate your name and where you're connecting from. As for the rest of the participants, we will just auto-generate a breakout rooms so that everybody will just be posted in different rooms. And I think that's also to enhance best practices so that we can learn on how Lusaka, how Mchinga is doing their cases, and it gives us an opportunity just to see how they are doing there. So without further ado, I want to just thank Dr. HACHAAMBWA and just call upon him to introduce himself, and then we'll be able to share the slides from here. Dr. HACHAAMBWA.
Good afternoon, network. Good afternoon, everyone. I'm pleased to be to join you today and to present today's didactic. We have a great number of cases which are very excellent. So what I'll share is sort of the basic information that's recommended by the Ministry of Health and also the World Health Organization. But often the guidelines can only go so far. When you go into real life situations, you find that you face the challenges that guidelines do not address. And I think all the cases that have been selected today really address that very well, where you can follow the guidelines and still be at a loss when you are faced with the situations that are in the cases. So I urge everyone to stay on for the cases and actively participate. I think what I'll share is just the basic information that you need to know, but I think most of the learning will be from the cases that we give. So my name is LOTTIE HACHAAMBWA, as was introduced. I'm an infectious disease physician. Can go to the first slide. So the objectives for our session today are to define treatment failure and also look at the causes of treatment failure, and then go on to discuss the eligibility criteria and the agents for changing treatment. When you need to switch people who've failed treatment, what can you switch them to? And that's where the cases that we have will really be very, very good in discussing this in a little more. And the fourth objective is kind of related, managing recipients of care who failed the first and second line. So what happens when someone starts treatment? The goal of treatment, as you all know, is to achieve viral suppression and also achieve immunological response where the CD4 count improves from what it was before treatment, especially if it was very low, to a very high CD4 count. And also to reduce morbidity, to reduce the risk of serious illnesses such as tuberculosis, cryptococcal meningitis, pneumocystis, pneumonia, and other very serious infections. So the first few months of treatment are very crucial in someone's treatment history. During those periods, that's when viral suppression could be achieved. So the goal is to achieve viral suppression within the first 6 months or so. But also during that period, that's when there's quite a number of things to pay attention to. And so I'll just highlight those things that must be paid attention to during those first 3 months, especially. For someone who's never been on a lifelong treatment, suddenly they start medicine, which they have to take for the rest of their lives. They may initially find it difficult to be adherent to treatment, this new treatment, especially now that we start treatment as soon as someone is diagnosed with rapid initiation of ART. Some people may still be going through an adjustment phase of coming to terms with their diagnosis, and also getting used to taking a number of pills. So this is a risky period in terms of adherence. There could be early treatment failure that occurs during this period, which could lead to drug resistance. The other challenges that come during the first few months of treatment are the risk of opportunistic infections. There could be some that were already there and they just become unmasked when somebody gets started on treatment. And there could be some that were actually not very clinically observable before starting treatment. And then once you start treatment, they get worse. So you can have IRIS, immune reconstitution, inflammatory syndrome. And then you could also have adverse drug events, drug reactions such as drug hypersensitivity, or any of the serious drug reactions that you could get. There's also mortality, early mortality. That was an issue several years ago. I think it's still an issue for people who've either stopped treatment or those that are newly initiated on treatment. The risk of early mortality is quite high. So when do you suspect that someone has treatment failure? So the long and short of it is that you expect viral load to be suppressed within 6 months of treatment. So if someone has been on treatment for at least 6 months and they're not suppressed, that's if you've done a viral load, then you'd be concerned for treatment failure. But before you do a viral load, at any other point, what can prompt you to think that there could be treatment failure in a particular individual? So this could be presenting with, someone could present with an opportunistic infection, either a new or recurrent event indicating either stage 3 or stage 4 disease. There are some conditions which even a stage 3 is sufficient to suggest that there could be treatment failure. But generally for all those stage 4 conditions, that should prompt a viral load testing. Even though they're not due for their annual viral load, if someone presents with cryptococcal meningitis, for example, or any stage 4 disease, they should be evaluated for treatment failure. While CD4 count is no longer recommended as the main way of monitoring viral load, there are situations where, though that shouldn't be the case in most of the facilities, but CD4 count, there's a definition for diagnosing treatment failure using a CD4 count. The main mode of diagnosing treatment failure is viral load testing. And then for people who have both treatment failure and advanced HIV disease, CD4 count and viral load should be done at the same time because there's a package which they should receive. There's a package for advanced treatment for advanced HIV disease. So that package requires that people receive, have both a CD4 count and viral load done. So that's kind of a special group of individuals. And there are special echo sessions that are done for advanced HIV disease. Next slide. Okay, the first poll question is, a man in his 30s is diagnosed with HIV disease, and they developed generalized myalgias and progressive weakness of the legs during the previous 6 months. The weakness was greater on the right than on the left, and it's associated with sharp pain in the left flank and mid-lower back that radiated to his thighs. Basically, they have radiculopathy. And because of that, they have several falls. So they have frequent falls. Investigations confirm toxoplasmosis, which is caused by Toxoplasma gondii, which is one of the stage 4 conditions. We are used to cerebral toxoplasmosis, but in this case, it was actually toxoplasmosis affecting the spinal cord. There's extracerebral involvement. The patient has been on ART for 2 months. And for some reason, viral load was done at 2 months, and it shows a viral load of 10,000 copies per ml. What's your next step?
So much for highlighting that case. I hope the network, we've been able to see that case. And so I will just share the poll. Maybe you can now poll your answers. What are your next steps? Do you switch second line regimen immediately? You continue current ART regimen and repeat the viral load in 4 months? Do you switch to third line ART? Do ESC and repeat viral load after 3 months? So what do people think they would do? You have this 30-year-old man who's developed a polyradiculopathy, having frequent falls as a result of the code being affected by the toxoplasmosis, and he has a viral load of 10,000 copies after 2 months of treatment. What is your next step? Okay, so let's see how we are doing. What do we think is the next step? Please be courageous. You can say something. Pick something of the next step. These are the real life sort of situations that we encounter as we are actually providing care. And very interesting scenario. Okay, so we only have about 40% that have polled. What about the others? Let's give it a shot. Okay, so I'll end the poll right now and share the results. So Dr. Hachaaambwa, I'm not sure if you can see how the poll has gone. This about 50% think they would continue current regimen and repeat viral load after 4 months. The others think they would do ESC and repeat viral load after 3 months. So I guess we'll pick up as we go on in the presentation.
Okay, thank you very much. Interesting results. I hope people are not thrown off by the exotic scenario. It could have been any other OI, but I happen to pick one that's a little unusual, just to let you know that toxo can also affect other parts of the body. So let's go through the WHO definitions of treatment failure. So the main one that we use is virologic failure, which is defined as a viral load more than 1,000 copies per ml based on 2 consecutive viral load measurements, which are done 3 months apart with enhanced adherence counseling after the first viral load. So you do a viral load, it's high, and then you do EAC, and then you repeat it. If it's still high and it's above 1,000, that's virologic failure. The other alternate definition is if someone gets switched. Let's say someone was on an NNRTI-based regimen. This is efavirenz or nevirapine, which we don't use much anymore. And after a first viral load, they are switched. That also meets criteria for treatment failure using virologic definition. And then an individual must have been on ART for at least 6 months before it can be determined whether they have the regimen has failed or not. You can suspect treatment failure based on clinical criteria. And there's also a CD4 count that's given here. So for clinical criteria, it's a new or recurrent stage 4, WHO stage 4 condition after at least 6 months of treatment. For certain conditions like tuberculosis and severe bacterial infections, such as meningitis or pneumonia, even a stage 3 condition, such as one of those, may indicate treatment failure. And then in the unlikely event that there was no viral load available readily, the CD4 thresholds for diagnosing treatment failure a CD4 count of 250 cells per cubic millimeter following clinical failure, and also one that's persistently below 100,000. There are all kinds of problems with using CD4 count as the main monitoring for treatment failure. And then just keep in mind that certain infections may cause a transient decline in a CD4 count. So those are the three criteria for definition of treatment failure. We mainly use the viral load, which is a viral load above 1,000 copies per ml. Next slide. Okay. So what causes treatment failure? Again, we're all very familiar with this. They're just categorized. Go on to a table. So there could be divided into several groups. You could have patient-related causes, HIV-related, that's the virus itself, and also ARV-related. So when someone takes medicine and it's not working, or they say they're taking medicine, there are several reasons why it may not be working, why the viral load may be high. It could be that they're not taking the drug, or they are taking the drug, but there's drug-drug interactions with other drugs, either other ARVs, or other drugs. Or it could be that the drug is being taken and there are no interactions, but there are metabolic conditions that lead to there are malabsorption issues. So it could be chronic diarrhea, it could be other things that lead to poor absorption and metabolism of the drug. So for the patient-related, this is mainly related to not taking the drug. So there are all kinds of reasons why individuals may not be taking their drug, or why they may be taking their drugs intermittently. So it could be that they're very sick. They could have comorbid conditions that make it very difficult to take their drugs. There could be social and psychosocial aspects. And here you can think of things like substance abuse, alcohol abuse, social situations for our adolescent and pediatric population. Even though we focus on adults, a recipient of care who's an orphan who's moved from house to house, has no stable housing, that could be an issue. There could be individuals that are not able to routinely come for their appointments and receive treatment. So access to ART. It could be tolerance to the regimen, the pill burden, especially for those that are on third line or other regimens. So all those are factors, patient-related factors. And then coming to HIV itself, the virus, it could be that the virus could be resistant, either primary drug resistance or acquired drug resistance. Primary is where someone is infected with a virus that's already resistant, and acquired is where the virus develops resistance during treatment, usually due to lack of good adherence. And then there are some drugs that are innately resistant to some viruses that are innately resistant to certain drugs like HIV to certain ARVs. And then the high viral load prior to treatment. Again, if you have a high viral load, say 1 million copies, 500,000 copies, all those are factors that can lead to lack of viral suppression. And then factors related to the medicine itself, it could be suboptimal pharmacokinetics. This is where we talk about drug-drug interactions, absorption of the drugs, and the choice of the regimen. Is it the most potent that's available? So it may not be very potent. And then drugs can also be divided into those that have a high genetic barrier to resistance and those that have a low genetic barrier to resistance. So drugs like lamivudine and emtricitabine only require one genetic mutation in order to become resistant. And then efavirenz and nevirapine, NNRTIs in general, also require just a few mutations in order to become resistant. Whereas second generation protease inhibitors such as darunavir require lots of mutations before they become resistant. Second generation integrase inhibitors, such as dolutegravir, also have a high genetic barrier to resistance. So the genetic barrier to resistance affects whether someone develops resistance or not. And then our prior exposure to suboptimal regimens can also lead to resistance. Food requirements, drugs like rilpivirine are supposed to be taken with food. So if they're not taken with food, the pharmacokinetics may be affected. Adverse drug-drug interactions and reactions. So if someone is on a protease inhibitor, such as atazanavir, and then they take a proton pump inhibitor for acid reflux, there could be drug-drug interactions which affect the absorption of the atazanavir, and then prescription errors. We give a number of our drugs in combination. Sometimes someone may be taking TLD, which is 3 drugs in one, and then at some point, if we run out of the combined drug, they could be given 2 drugs, which are Truvada and DTG on its own. I've had situations where someone actually takes 1 drug for several months, thinking that is still the combined drug. So there could be errors like that. So viral load testing, as we mentioned, is the main way in which you diagnose treatment failure. So early and accurate indications for treatment failure and the need to switch to second line is very important. It reduces the accumulation of drug-resistant mutations, and it also improves clinical outcome. Next slide. So, WHO uses a viral load of 1,000 copies per microliter in order to diagnose treatment failure. You find different guidelines use different thresholds. So this just summarizes some of the studies that looked at what happens if someone has a persistent viral load, which is above a detectable level. Let's say it's above 50 copies per ml, and yet it's below 1,000. So there was a review, which is cited here, which looked at 31 studies that showed the prevalence of low-level viremia. And in those studies, it ranged from 3% to 26%. And each study had different definitions of what low-level viremia is. It was generally defined as 1 or more viral loads for a single person of between 50 to 1,000 copies per ml. And the main thing, take-home point that I would want you to get is that for people that had viral loads between 50 and 200 copies per ml, there was a trend towards future virologic failure. And then for those that had viral loads, low-level viremia, between 200 and 500 copies per ml, there was a statistically significant predicted future virologic failure. So even though there's this range of 50 to 1,000 copies per ml, obviously the closer you are to 1,000, the possibility of eventually developing failure is probably higher in such an individual compared to someone whose viral load is 75, for example. Both of those have detectable viral load, but one is probably more likely to develop treatment failure in the future than the one who is closer to undetectable viral load. Next slide. So what happens to people who have treatment failure? How should they be managed? So I'll start with those that are severely ill. So for those who are very ill, the switch to a new regimen should be expedited. Our guidelines have an algorithm of what to do when someone has a detectable viral load. But for those who are severely ill, an expedited switch could be considered, and this is to reduce the risk of mortality. And this can be done by possibly reducing the interval between the first and second viral load tests. Instead of doing one now and then waiting until 3 months, exactly 3 months later, it could be done maybe a little earlier. And then also ensuring a rapid turnaround once you do the viral load, instead of waiting several weeks or even a month before getting the results. If it's possible to expedite the turnaround time for the results for that particular individual so that you can act on them. So those are some of the things that can be considered for individuals who are severely ill in order to expedite the switch to a new regimen. For the rest of the patients, we can go to the next slide. So you could follow a number of steps. Again, something that you're all very familiar with and you do all the time. A thorough assessment of the known factors. We talked about patient-related factors, the virus-related factors, as well as the drug-related factors. So exploring any of those factors that may lead to treatment failure and then dealing with them. Obviously, the ones that you probably will be the subject of enhanced adherence counseling are those that are patient-related. So there are several barriers in the patient-related category, such as the timing of the dose, the side effects, the comorbid conditions like depression, substance use. All those could be dealt with in enhanced adherence counseling sessions. And then if there are issues with errors in medication, all those can be corrected. And then if there are issues with pharmacokinetics, drug-drug interactions, again, getting a very detailed history on what are the medicines someone may be taking. All that's very important information. And then once you explore the potential causes of virology failure in depth, then steps should be taken to improve the virology outcomes. Next slide. So some of the principles in choosing a new regimen, again, there are guidelines that we follow, but the principles that underlie those recommendations are that ideally a new ARV regimen should contain at least 2, preferably 3 active drugs. Now, information is changing. There are new trials that are going on that are providing new information that may change what we say about this first bullet point. But for now, ideally, it should be good to have at least 2 or 3 fully active drugs. And then thoroughly review the patient's treatment history, and then review any previous or current genotype results. Those will be very helpful in choosing the new regimen. And then try to determine the mechanism of action of the drug. Again, when constructing a regimen, it's good to have a drug that has a new mechanism of action so that we know that it works very well. And then some drugs may still have some partial activity against the virus, even though there's some resistance or they've been in the previous regimen. An example is emtricitabine and lamivudine. They're usually continued in the next regimen, and there are several reasons why that occurs. Next slide. Okay, the next poll question. A man in his 40s with a history of HIV infection was admitted to a hospital with a 1-month history of increasing shortness of breath. A chest X-ray showed bilateral pneumonia, which ended up being pneumocystis pneumonia. Initially, azithromycin and ceftriaxone were administered IV. However, symptoms worsened. 5 days later, a repeat X-ray showed bilateral pneumothoraces. So pneumocystis pneumonia can cause a pneumothorax. And this individual had been on treatment, tripla, for 14 years. What are your next steps regarding his ART regimen?
Thank you so much for that good case aid again. So I'll just share the pause. So what are your next steps with regard to this ARV regimen? Check a CD4 count to confirm treatment failure. switch his regimen to TLD immediately while investigating the OI, do EAC and repeat viral load after 3 months, plan for an expedited switch to a new regimen. So dear network, please go ahead and take your pick. Which one is your next step here? So it's a 40-year-old man on treatment for 14 years on TLE, and 5 days, he's given a history of with pneumothorax on chest X-ray, and it's had a history of for 1 month history of increasing dyspnea. What are your next steps? Very interesting case, Dr. Hachaaambwa, this one. Very common.
I actually gave away information which I shouldn't have given. I think that explains why it's so varied, but I was to explain.
Yeah. Okay, so I can see people quite have variable responses here. It's like 25%, 25%, 30%, 15%. Yeah, very interesting response as well. So these are some of the difficult cases we encounter in our practice, so we shouldn't be too surprised. So allow me to end the poll. At least we have about 50% people have clicked an answer. And
okay, so interesting results. Almost a third for B, C, and D.
Yeah.
So there was a split there.
Yes.
So again, maybe just to comment on this question. So there's probably, what I would suggest is the answer here is D. So because I've already discussed this, that for people who are severely ill, you want to do an expedited switch to a new regimen. And the expedited switch, we mentioned that it's it could be a faster turnaround of viral load results and all kinds of things. So the reason why A is incorrect is that this patient most likely has treatment failure. So to go ahead and do a CD4 count just to confirm treatment failure, I think is not the most appropriate. Viral load is better used for checking treatment failure. And then switching his regimen to TLD immediately while investigating the OI, I think that's why I inadvertently gave some additional information. So the initial where the scenario is given is that this could also be any of the infections in the lungs. In fact, the patient could have 2 infections in the lungs. So pneumocystis, pneumonia, they could have tuberculosis. So I want to do a little more investigations before starting the patient on a new regimen. So for a number of OIs, in order to reduce the risk of iris, you'd want to, if someone is not on ART, you want to give a bit of time to treat the OI and then start the new regimen or start ART to reduce the risk of iris. And that's the reason B. While it is a good choice, may not be the best answer in this case. And in case they had tuberculosis, you want to take into account the interactions, the drug-drug interactions. So you want to thoroughly investigate, ensure that there's no tuberculosis in addition to whatever else. And then C, again, not a very good choice because this patient is quite ill. So you don't want to prolong the switch to a new regimen. You can go on to the next slide. Okay, so these are the options that we have for switching to second-line ART. So basically, if you have an NNRTI with two NRTIs, your second line option is either AZT3TC with DTG or AZT3TC with a PI. So as if you have two NRTIs and an NNRTI, so which is the first option there. So you can either go to AZT3TC with DTG, or you can go to AZT3TC with a boosted PI. And the guidelines mention both opinavir and atazanavir. The WHO does mention other options as well. And then if you have two NRTIs with DTG, so there's no, we don't have much clinical data on this. So these recommendations are based on extrapolations from the principles we've discussed, and also what happens when you have an NRTI with two NRTIs. So basically you're switching the NRTI backbone and then replacing the entity in this case, which is dolutegravir, replacing it with a PI, a boosted PI, on the prediction that because you are using a new drug, so it should work quite well. So these are all very simplified scenarios. They assume that somebody has not been on ART before, they don't have a complex treatment history, which I'm glad that the cases that we have are not as simple as this, that we can think through these options. And then the third one is a bit similar. It's just that there's ABC there. And then the last one, the last option, ABC3TC and efavirenz, is similar to the first option. So those are the options that are given in our guidelines and also the WHO guidelines on what to switch. So basically you're replacing either the DTG or the NNRTI with either a PI or an NST, an integrase strand transfer inhibitor. So again, this everyone should be very familiar with, because that's what the guidelines say. Next slide. Okay, again, just to summarize what we've been discussing on the algorithm to follow. So someone gets started on ART, they are switched, they are started on ART, you monitor first viral load is done at 6 months, and then you repeat it at 12 months. And then if everything's okay, you'll go on doing every year. If the viral load is undetectable, meaning it's either below 20 copies per ml or less than 50, you maintain the ART regimen. The second option is if the viral load is between 50 to 1,000 copies per ml. Now, this is what the WHO says in their last year's guidelines, that you do EAC and repeat viral load after 3 months. And then if it's above 1,000 copies per ml, again, you do EAC and repeat viral load after 3 months. And after repeating the viral load, if it's undetectable, you maintain the regimen. If it's still in that range, you maintain that in the range of 50 to 1,000 copies, maintain the regimen, but continue EAC and repeat viral load after 3 months. If it's above 1,000, that's the definition of treatment failure based on the World Health Organization. 2 viral loads that are interspaced with EAC, and there are at least 1,000 copies per ml. You switch to the appropriate regimen. So with the first option, if you repeat the viral load and it's above 1,000 copies per ml, and if they're on an NNRTI-based regimen, you switch to appropriate regimen, again, based on the previous table that we had. Next slide. So again, this, just quickly go through it, which a study which followed up individuals with treatment failure who are on a boosted PI regimen, and the outcomes are reported at 64 weeks. Of the 198 participants, 6 died before the study end period, and then 130 achieved viral suppression and continued to second line. And then 63 were switched to third line. So these are individuals who had non-treatment failure to a boosted regimen. So what happens after and had enhanced adherence counseling? So those are the 3 outcomes. Some died, the majority were able to suppress, and then others, a third of them, ended up being switched to third line treatment. So it's similar to what we've just been discussing, except this is referring to individuals who are on second line. So this study reinforces the need for adherence counseling. You notice that a number of people resuppressed, 2/3 of them resuppressed on adherence counseling. And there was no resistance testing that was done in this situation. Next slide. Okay, I think we'll skip this. We can go to the summary slide. Okay, so in summary, what I've been trying to get across is that individuals who've been on treatment for at least 6 months and have a viral load which is above 1,000 copies are failing treatment. They're at risk of progression of HIV disease, and so they must be evaluated for treatment failure. And the commonest cause of treatment failure is poor adherence. So in evaluating all those factors that we mentioned, patient-related, drug-related, and virus-related, the commonest by far is lack of adherence. So adherence barriers must be evaluated and corrected before therapy is changed, with the exception of seriously ill individuals who require expediting of the switch so that they don't die. And then patients who are failing treatment are prone to opportunistic infections, and a comprehensive evaluation of OI should be done. This is part of what's in the advanced HIV treatment package. Thank you.
Thank you so much, Dr. Hachaambwa. We really appreciate this very valuable information that you shared today. I have not seen any questions in the chat box, but I think before we move there, we can discuss this first poll question. I know it may have come out during your presentation. Perhaps we could just do a repoll and just see what people's thoughts are following the discussion. So, dear network, please, you can poll again on this particular question. We have a 30-year-old man recently diagnosed with HIV, developed generalized myalgia, progressive leg weakness, and during the previous 6 months. He's been on treatment for two months, and his viral load remains high. He was found to have toxoplasmosis on the cord that has affected his limb function. So, what are your next steps? Do you switch to second line regimen immediately, or do you continue current therapy regimen and repeat viral load in 4 months, or do you switch to third line ART, or do you do ESC and repeat viral load after 3 months? So please, network, go ahead and poll so that we can discuss this answer, this poll questions. Dr. Hachaambwa, maybe you could make a comment on this one.
Yes, sure. So the main point of this question is that a definition of treatment failure is when viral load is detectable high after 6 months of treatment. So I think the key point there is that this patient has only been on treatment for 2 months. So they actually don't meet the criteria for treatment failure.
You know what I like about this scenario is that it brings things into reality, and this is where we really get confused to say the viral load is still high and is having this problem, these issues, but we were quick to suggest that it could be treatment failure. I like the way you've presented it. It emphasizes to say think about this before you can think about treatment failure. I guess that was the main point of the 4 questions, eh?
Yeah.
No, thank you very much. I hope network will have taken note of that. Then you did run us through this particular poll question. I don't know if there are any you still need to.
Yeah, so unless there are questions on this poll question, I think we kind of discussed it. The optimal option here is D, which is expedited switch. B is also a possible option as long as you've taken into account. By immediate, obviously that can vary. It could be within a week or two, within which still would probably fall under the category of expedited switch. So D is the better option for this question, and we discussed it.
Yeah, no, thank you very much. Another very practical case that we see in our facilities, not theories, but things that we encounter. And we really get a challenge on how we proceed with management. I guess the principle here is that this is a very sick person, and with the choice of drug that you have here, the NNRTI, so you really want to maximize on the air, optimize the ARVs on this particular one. Thank you so much, Dr. Chamba, on this very important presentation. So I'm just going to ask the teams that are presenting cases to get ready, as we will be breaking out at this stage. But before we do that, I'll give an opportunity for 1 or 2 burning questions that we may have from the network. Please, if you have a question, you can raise your hand, then we'll unmute you. And just to clarify on what the presentation has been, please go ahead and raise your hand, and then you can ask your question. Himabala Collins, please go ahead and ask your question. Then we'll have Nchimunya ask the question. Himabala, you can unmute. IT, kindly help. You can go ahead, Himabala.
Thank you.
Just get close to the mic so that we can hear you.
Hello, are you getting me now?
Then clear now.
Yes, we can hear you.
All right, thank you. So my question is based on this very poor question. I know you mentioned that this is a severely ill patient. That's why we have to do an expedited switch to a new regimen. But I wanted some more maybe details on what exactly are the parameters we are following to determine whether this patient is severely ill. I'm seeing this in the light of maybe another patient that comes in. How are we going to determine that they are severely ill? What parameters should we follow so that we decide on whether we are doing an expedited switch or maybe just do EAC? Thanks and all.
Okay, thank you. Dr. Kozia, do you want me to answer this, or we hear from Dr. Manzi also? Okay, I'll go ahead and respond. So in this scenario, the severity of the illness is the advanced HIV disease. So this patient has a serious opportunistic infection. And when someone has an OI, especially stage 4 OI, they are very severe disease, their CD4 count could be very low. So if you were to follow what happens for everyone else, you would do a viral load now, and then do EAC, and then wait for 3 months, and then do another viral load before switching. And in reality, we know that you will not get that viral load exactly at 3 months. When it's done at 3 months, it may take another month or so to get back. So you could be talking about anywhere from 5 to 6 months before you're able to act on these results in someone who's got severe disease and is at the risk of other opportunistic infections and even at the risk of death So that's the reason. So basically someone was a stage 4 condition and has advanced HIV disease. So for such an individual, you treat them differently than someone who is stable in the community, has no OI, and has a viral load which is high. I hope that makes it clear that for people who are sick, you act a little more quickly in order to reduce the risk of death.
Are you okay, Collins? I think that gives better.
Yes, it's more clear now. Thank you.
All right, thanks. Dr. Manzi and then Dr. Kachuka from Ptauke. Dr. Manzi, go ahead.
Good afternoon, Dr. Ziambo. Good afternoon, Dr. Hachambwa. Thank you so much for that wonderful presentation. My question is regarding the pregnant and breastfeeding women. So in a pregnant and breastfeeding woman with a high viral load, do we also consider expediting the switch to a new regimen, or we enroll them in EAC? What is your take on that? Because we have found so many different things on the ground. So I would like your comment. Thank you.
So much. Maybe we can hear from Kachuka as well before Dr. Hachambwa response. Kachuka.
Okay. Thank you, Dr. Kozia. It's okay. My question has been asked by Dr. Collins. Thank you.
I don't know what's behind that.
Dr. Hachambwa.
Yeah, Dr. Zamba, I don't know if there are any others that are any of the panelists that would like to take that before I take it.
Yeah, let me just check which panelists we have here. Any comments from our panel of experts? I think you may go ahead, Dr. Hachambwa.
Okay, yeah. So again, Dr. Manzi, that is correct that for pregnant women, you do the same thing because of the risk of, you want them to get suppressed before 36 weeks. And while new drugs like dolutegravir reduce the viral load very rapidly, it could happen in as quick as 2 weeks. You don't want to wait too long before while dealing with enhanced adherence counseling, waiting for new viral loads. So for pregnant women, yes, you could follow the same pattern and expedited switch in order to reduce the risk of transmission to the baby. And there's another question in the chat. Can I go ahead?
Yes, there's a question. Yes, go ahead.
Yeah, so this is an interesting topic from Montula on actionable viral load of 50. So I think for these, those that are above 50 and below 1,000, so WHO, as I mentioned in the guidelines, last year's guidelines, they mentioned that you could do enhanced adherence counseling and then repeat the viral load. Getting an echo. Okay, so they mentioned that you could do enhanced adherence counseling and repeat the viral load after 3 months. The closer it is to 1,000, obviously the higher the risk of developing treatment failure eventually. So the bottom line is that I think when a viral load is detectable, the main things that you worry about are they likely to fail in future? And then the next one is, are they likely to develop resistance? So for very low viral loads, like below 100, let's say 75 and others, so those are viral blips for which you really don't need to take any action. They're just a variation around a mean. If you check viral load today, let's say you do a viral load and it's 50 copies per ml, you do it tomorrow, it might be 25. So there's an acceptable variation. Just like in nature, there's a variation which is acceptable around the mean. So let's say someone has a steady state viral load with a mean of 25 copies per ml. Depending on the day that you check it, it might vary. Sometimes it will be low, sometimes it's high. So if it's just a blip, it has no significance. It doesn't predict future treatment failure. It doesn't predict future resistance. But the higher it is, the closer it is to 1,000 or even above 1,000, that's where there could be problems in future. I think that's a comment that I can make on that without going into too much detail. Hope that answers that question. And then there's, okay, there's another follow-up question.
Yes, yeah, on pregnant breastfeeding women. Just I think
That was actually a follow-up on the same one, the guidelines to provide EAC for viral load. Yeah, so this is what the WHO guidelines state. They have not, so those guidelines have not yet been incorporated into what we do in Zambia, but obviously it's usually just a matter of time. They get incorporated. I just wanted you to be aware of what WHO says. And then the follow-up question on pregnant and breastfeeding women. There are cases where HIV viral load in pregnant and breastfeeding women is due to woman not taking the first line drug. Is second line supposed to be the solution, considering that second line has more tabs? So a current first line treatment is TOD, which is a single tablet. And it's actually a very powerful regimen. So the current drugs that are used are very powerful if it contains dolutegravir. So for such an individual, I deliberately didn't go into details of some of the newer information. Maybe we can discuss it after the cases that have been presented by the provinces. Some of the new studies like the Nadia study or even the Vicen study, which was done here in Zambia, which maybe make us relook at the recommendations for second line regimen. So for this situation, I think it depends on what the first line regimen is. If it's dolutegravir based regimen, one could consider continuing it and then just go on to adherence.
Dr. Hachambwa, I've seen a question from Dr. Bosco. I think that was just a case scenario. There was no explanation to why they took that second, the viral load in 2 months. So I think this time we can go into breakout sessions. I'll ask the IT to help us do that. So this will just be automatically generated. So everybody will find themselves in different rooms. And then our facilitators in the rooms and the presenters kindly get ready to share your presentations. So I think with that, we'll come back after 25 minutes of that session, and then we can come back and discuss. So we'll go into breakout sessions. IT, kindly pick it up. Thank you.
Then January 2019, part of the information will be found in the next slide. So January 2019, we substituted nevirapine with efavirenz. This was due to poor adherence. The boy at that time was an adolescent attending school. So he had difficulties taking the drugs, especially in the morning, nevirapine, which contributed to the rise in the viral load, as we shall see in the next slide. So we had to put him on tenofovir, lamivudine, and efavirenz to help improve adherence. By December 2019, due to high viral load, we had to switch to second line, where we had to put him back on zidovudine, lamivudine, and lopinavir boosted with ritonavir due to treatment failure. As we shall see in the next slide, how the viral load profile was. By March 22 this year, between December 2019 and March, the viral loads which were there before the latest viral load, which is 109,000, he had suppressed. The first suppression was 29, and the next was less than 30 copies. That was in 2020. 2021, we don't have any results, but 2022, when we did the viral load in March, we found that the viral load has gone up to 109,000 copies per mil. We maintained him on that. We didn't meet him in March, April, May. In June, when he came, we noticed the viral load was
as a laboratory. The physical examination findings were normal, as indicated here on the right-hand side of the slides. And these are the results, mostly just the viral loads. You can see there that we are still waiting for genotype. So could there be any questions or clarifications over the case before we attempt to answer the questions being displayed now? Any clarifications from anyone on the call? I do not see any hand. I don't know if there's anyone with anything to say. I think you can just unmute and go ahead so that we even queue on time. As I try to check. Okay, Dr. Rupia Manfred, please go ahead. I've seen a hand raised. Please go ahead as I check through the chat box.
Yes, Dr. Rushinga.
Dr. Rupia.
Yes,
okay, thank you so much, Kabwe General. So I see that Dr. Mwenya is still not with us, so I'll just go ahead and try to facilitate for this session. Can I just confirm which ones are our experts in this group? Just before we go further, I can see there are 2 hands already. But before we do that, can I just confirm our expert presence? Dr. Manzi, are you one of the experts?
Good afternoon, Dr. Mouma. I'm not one of the experts, but Dr. Bosco is our expert.
Around, yes.
One of the experts?
Yes, I will help on that, please. Thank you.
Okay. Okay. Dr. Zimba, I can see your hand is raised.
Thank you. Thank you.
Yes.
I just wanted maybe to find out if we had done some genotyping in this patient, and then also look at the when we come to this part of addition of DTG, whether we could have considered adding TAFED together with the DTG. Thanks.
Okay, thank you so much, Dr. Kevin. Also, for those that may have joined maybe in the middle of the case, as Kabwe is preparing to respond to the question, some of you can also type in the chat box so that you get clarity on the case. They are presenting a male who's 22 years old, has been on ART for 9 years, started in 2013. Started on AZT, 3TC, and NVP. Then 3 years later, which was in 2016, they replaced the AZT with TDF so that they could keep the AZT for later. 2019, they switched the NVP to EFV. And then in the same 2019, December, they did viral load. So for a client who was previously suppressed, they found that he had a high viral load. So they switched to second line AZT, 3TC, and LPV. They are saying in the whole of 2020, he was suppressed, but in 2022, he became unsuppressed. So then they did some switches, and so they switched the LPV in the second line to DTG. So that's basically some of the summary of the case. So Kabwe, Dr. Zimba has asked a question, and I think it's a similar question in the chat box. Was their genotype done?
No, we have not yet done any genotype.
Sorry, Kabwe, please go ahead.
I was saying we haven't done any genotype testing yet.
Okay. So no genotype has been done.
The challenge is, even if we collect, if we were to send the boy to Zaka, he's just staying with an aunt who is doing nothing. So maybe funds will be a challenge. But transporting the sample to Zaka will be a challenge.
Okay. Do the clients transport the samples themselves?
No, we send. It's either we send the client to Zaka, the physician form for genotype, or we collect. Then we use the hospital transport. If we have any transport going to Zaka, then we take the samples. But we haven't done that in the recent past.
Okay. The second question, which is really a two-part question, is was IAC done? And if it was done, at any point, what were the barriers to adherence identified during IAC? Did you take note of that question?
Yes, we did.
Okay.
Yes, IAC was done. IAC was done several times, but the barrier at first, when he was on Nevirapine, the challenge was taking Nevirapine in the morning when going to school. So I was only taking once plus tenofovir. Then the other challenge, when he was put on Lopinavir, the 3 tablets in the morning, the 3 tablets in the evening. When he's out playing, he said he was failing to take the 3 tablets in the evening. Morning he would take, but the evening ones, it was a challenge. No wonder in June we decided to put him on DTG.
Okay. How is the sample courier system for VL in the province? Then before you answer that, I think Dr. Kevin, you can also go ahead.
All right. So thank you. So I've been listening to the challenges. So maybe a few suggestions I would make for this patient is that one, we are talking of adherence because he likes playing and not being able to take. So we switch to AZT, 3TC, and DTG. When we look at the resistant profiling, this patient can actually benefit on being on Tafed while we are waiting for the genotyping. So we can do genotyping, put the patient on Tafed, which is a once-a-day regimen, and be able to take it. Then secondly, let's ride on the courier system. I know we are saying we have to bring the specimens to Lusaka. We have TB patients in Central Province whose specimens are coming to the chest disease laboratory for culture, for drug-resistant TB. We can arrange and courier the specimen so this patient comes and gets a genotyping, and then we address that and also address the barriers for IAC together. Thank you.
Thank you so much, Dr. Kevin. I think that also probably does answer both questions. Do we have any other comments? Another question, Kabwe, that you need to just take us through is, are there any adolescent support groups at the facility?
We have an adolescent support group which started in 2013 and is part of the team.
Okay. I think other people like Nyanga, Renford are still trying to get clarity. How was LPV dosed?
Looking at his weight, he's above 35 kg, so he was on adult dosing.
Okay, thank you. Do we have any other comments? We just have about maybe 2 or 3 minutes. So can we get some comments before Dr. Bosco comes in as well? Do we have any other thoughts about how we could have managed this client, having been treated with AZT initially? What other things can the team do? Dr. Lunga, please go ahead.
Thank you. So I think the aspect of enhanced adherence counseling is one thing that we need to really stress when we're talking about patients that are failing. When you do adherence counseling, your main job, particularly at the first encounter, is to ascertain or to establish what is the reason for the poor adherence. When you ascertain what that is, then you are going to then tackle that during your subsequent IAC sessions, such that by the end of the 3 months, you should have addressed that issue. And once you address that issue, you have the patient almost always, over 90% of the times, they'll actually suppress, such that you should not rush to the point of changing therapy, because if you change therapy and the reason for the poor adherence is not tackled, you are not going to sort out anything. You are just exposing the client to other antiretroviral drugs, and then they'll keep on creating resistant viruses to those newer drugs. So it's very, very important that at the first EAC sessions, you establish what the reason is, and then you tackle that throughout your EAC sessions. I just wanted to stress that. And then once you establish that really the client is adherent to treatment, but is still unsuppressed, then that warrants you switching to the next line of therapy.
Thank you so
Thank
much.
you.
Thank you so much, Dr. Lunga. And I think Dr. Kevin actually agrees with you. Dr. Bosco, any last comments before
Thank you.
we,
Thank you very much, team, Kabwe team, and everyone. Dr. Ziko, you're welcome to Kabwe. This is a very good case. I think Dr. Ziko have really read my mind. My key point is on in-nurse adherence counseling session. If you go in your guideline, Ringo, on the 2020 guideline, on page 65, there is a good summarized table we had put there on when you identify a gap for during EAC, you must address the gap together with the patient so that you clear or you resolve the gap. Then you move on before doing even the repeat of the viral load. That's one thing. And so we need to always be mindful. So we should not rush to change drugs, but the adherence part, the in-nurse adherence part is very important. Number two is you've changed from lopinavir to dolutegravir. That's purely a single switch you've done. Your patient is failing treatment. When the failing treatment, we need to do the entire regimen switch. So those are the things we are supposed to be doing. And when we are unsure, please, again, let's not rush to switch on the drugs. We have very few regimens have a courtesy of consulting our national line, the 704, and you, Kabwe people, you are very aware about that. And I'm glad to be in this group because I'm a Kabwe resident. So if you had called me on this case, I could have come, could have sat down and discussed this. Lastly, not the least, the genotype testing. I've heard you say that when you send the sample, you don't receive result. I've heard you say sometimes we send patient with the sample. Please, in Zambia, we don't send patient anymore any place. We do the sample referral, and there is no system which is 100% perfect. We might have gaps here and there, but I can assure you, the resistant testing or genotype is being done in Lusaka. You can do it in Ndola. I have patients from Western Province. I sometimes take their samples in Lusaka or in Ndola. So in the future, if you have such case, please get in touch with us. We can help you to track your result and give back to you to come so that we manage our patient based on a national protocol. Thank you very much, and thank you for everyone who contributed in this case.
Thank you so much. So thank you so much, Dr. Bosco. And we just have less than 50 seconds for us to go back to the room. So Kabwe team, please take note of what has been said. And if you look at the chat box, they are really stressing that maybe we try out thoughts, directly observed therapy for this client to make sure that he's actually taking these drugs. But also what Dr. Lunga talked about during the EAC, you really need to see what really is causing the problem. Because this is a person who you will start changing regimens, but nothing will change because that behavior, the barrier has continued, okay? And to tie it all up, Dr. Kevin also suggested that we put this patient on Tafet and we ride on the courier system that's provided so that we are able to
Good afternoon. Welcome back, everyone. I hope we had some very interesting sessions. Apologies to one of the groups that couldn't take off. We apologize for that. We hope it doesn't happen again. And so, as we want to conclude, I'm inviting everyone to go to the chat box. Kindly click on that link and then register. Please go to the chat box, click on that link and register your attendance. Very soon, we will be taking note of the registration, and then once it reaches a certain attendance, your attendance, then you'll be able to generate a certificate of attendance, which you can be using for your CPD points for registration with Health Profession Council. So please, it's important that you register so that your name can actually be taken note of with attendance for several times. And then we can offer you a certificate of attendance. That being said, I'll now invite Dr. Hachaambwa to give us a summary overview of what we've been discussed. I know in the different rooms, you may have received different recommendations, but since we had reached the 16-hour mark, we'll ask Dr. Hachaambwa just to give an overview on this case, on this presentation today. Dr. Hachaambwa, please go ahead.
Okay, thank you very much. So in short, summarizing the case scenarios, I think all of them started with 2 NRTIs with an NNRTI, and then the next drug regimen was 2 NRTIs with a PI, and then the third one was 2 NRTIs with an integrase inhibitor. So for most of those, I think for some of them, we don't have a repeat viral load yet. So based on this sequence, I think most of them should be suppressed, including those that are still waiting for a repeat viral load, because the most effective regimens, drugs that we have at the moment, at least in Zambia, for the integrase inhibitors is dolutegravir. And again, I'll mention the 2 studies, the Vicent and the Nadia study, which show that regardless of the mutations that may exist in the NRTI group, when you combine 2 NRTIs with, especially if those 2 NRTIs include tenofovir, when you combine them with an integrase inhibitor such as dolutegravir, you could achieve suppression. And then when you combine them in the Nadia study, if you combine them with darunavir, you could also achieve suppression, but we're not using that yet for second line. So I think all these 3 cases, except for Eastern Province, all these 3 cases eventually should suppress. So I think I'll just emphasize the same issue we talked about, enhanced adherence counseling, because poor adherence is the main reason why there's usually treatment failure. But so we're fortunate to have dolutegravir as one of our drugs. But looking at the cases, there's one of the lessons that you can learn is that sometimes the choice of the sequence of drugs was really functional monotherapy, because drugs from the same class were replaced with another drug from the same class when they were probably already resistant. So I think that's something to take into account when switching drugs. Consider if you're using drugs from a different class and the possibility that a drug might actually work. But overall, very good cases. I think that's what I had, Dr. Zambia. Thank you.
Thank you very much. What a way to summarize all the 4 cases that we had today. Thank you so much, Dr. Hachaambwa. You just have a way of putting everything together. We appreciate your availability to just continue to support the mentorship program and all the facilities that connect. We thank the different provinces that prepared the cases. We appreciate the time that you put in and you were able to join us and present. And so we are happy to end this session on a good note, and we will be able to see you in the next 2 weeks. Next week is the holiday. Hope you have a very good holiday and enjoy your